Good afternoon and welcome to the Maine Health Management Coalition's webinar on improving patient outcomes in diabetes. My name is Marie Stuckey and I'm the Member Relations Manager here. Happy to have Matt Peterson of the American Diabetes Association present for us today, and thank him very much for his time. We are going to start with a brief overview about the Maine Health Management Coalition for those who are tuning in who are not familiar with our nonprofit organization, and some information on upcoming events that members and some non-members may be interested in. After that, I will introduce Matt and he'll go through his presentation, and I wanted to let you know that this is recorded and will be archived on our member website, so you can access this later or share it with some of your colleagues. And at any time during the broadcast, feel free to type questions in the chat box, because we can share those at the end of the presentation, and I will relay your questions to Matt, and he can answer them at that time. So to just give you a little bit of background, the Maine Health Management Coalition is a multi-stakeholder collaborative. We partner with all our stakeholders to improve the health and maximize the value of healthcare services in the state of Maine for all its residents and for our members and their families. We're made up of 5 different stakeholder categories, including consumer organizations such as the American Diabetes Association, purchasers and employers, a group of health plans, brokers, and benefit consultants, healthcare providers, and affiliate organizations that support our work. So we reach our goals through 5 key initiatives, of which data is the foundation. We have the state's all-payer claims database, so we have all the claims for the state. We can do a lot of analysis with that data. We also reach our initiatives for high-value healthcare through transparency and public reporting on the safety, outcomes, and patient experience and cost of care, through member and consumer engagement by incentivizing and giving people resources and tools they can use to have a healthier population, through improved benefit design that rewards high-quality patient-centered care, and the same for payment reform. We explore payment arrangements that align with, again, high-quality patient-centered care at a reasonable cost. Some of the benefits of membership at the coalition include a variety of opportunities to network, learn, and influence the changes in healthcare. Our members have connections to other members, and they have valuable connections that way. They learn best practices in health plan design and workplace wellness. They have access to our outstanding data analytics team and can train leadership and staff through educational events and resources. We also are able to get our members some discounts on products and services at conferences and other vendor products. We have a lot of work groups that get together collaboratively to move the needle on change in improving healthcare. Webinars such as this are free to our members, and our members also have voting rights for key decisions in healthcare reform and for our board seats. So some upcoming work group meetings that you might want to put on your calendar. Our healthcare cost work group has something coming up on March 31st. They identify healthcare cost drivers and actionable strategies to reduce costs and preserve quality. The value-based insurance design clinical group meets on that same day, and they recommend benefit design for high-value services and shared decision-making. Our Pathways to Excellence clinicians and systems work groups are meeting on April 14th. They identify quality ratings and criteria for publicly reporting them. And also from our Pathways to Excellence behavioral health group, they will be meeting next on April 20th, determining quality measures for public reporting behavioral health issues. And we highly encourage attendance at our next all-member meeting taking place on April 28th. And we are going to have some more information forthcoming on that, but it's going to be a new way of presenting that meeting, and I think our members will really enjoy that. So mark your calendars for the next upcoming webcasts. In April, we've got telemedicine, legal and operational considerations, and recruiting, retaining, and supporting Maine's aging workforce. And then in May, improving population health outcomes through better nutrition. It's kind of a case study we'll be presenting there. And on the 25th of May, the financial benefit and legal guidelines of a successful wellness program. And you can sign up to receive information on our webcast on our homepage of our website. Here's just a logo slide showing some of our members that we appreciate. And without further delay, let me introduce Matt. Matt Peterson has been with the American Diabetes Association since 1993, first as managing editor of the association's professional publications, and then as director of the association's research program. Since 2001, he has directed the association's medical and professional education engagement department, which oversees the association's information on diabetes treatment management and statistics. The department is also charged with improving and expanding the ways in which the association provides services to its professional members and other healthcare professionals. Mr. Peterson has broad responsibility for ensuring consistent messages about diabetes throughout the organization. He also manages several educational initiatives for consumers and healthcare professionals, and is responsible for the association's management and dissemination of information about statistical aspects of diabetes. He oversees the development of the economic costs of diabetes study, as well as other statistical resources, including the ADA's contribution to the National Diabetes Statistics Report produced by the CDC. He developed his department and his department maintains the association's professional website, Diabetes Pro, along with a range of other materials and resources for patients and professionals. And with that, we're going to turn this over to Matt Peterson. Thank you so much, Matt.
Thank you for asking me to do this. There's some things that, let me click on show my screen. There we go. You all can see that?
Yes, we see it. That's perfect. Okay. Thank you.
All right. I'll be talking about some things that are my responsibility, some that aren't, but hopefully I can do a pretty good job of giving you an idea of what's important to ADA and improving patient care and some of the things that we are making available to help people do that. I'm going to start with a slide that's, in a way, to me, the bedrock of all of this. It's my favorite slide. It literally almost gives me goosebumps when I look at it. I don't know if people on the call are familiar with it, but this was the results of an analysis done by CDC folks led by Ed Gregg, published in New England Journal of Medicine last year, that looked how complication rates have changed over the last couple of decades. And for those who know their timeline of our understanding of diabetes, know that in late 1993, the seminal event in all of diabetes, other than the discovery of insulin, was the release of the DCCT that showed that intensive control of diabetes could reduce complication rates. And though this is observational data, we can't know it, I firmly believe that the publication of those results in 1993 and the subsequent attention to diabetes by both professionals and patients, the public at large, is why we saw this change. There are many other factors involved too, probably more to the heart of what we'll talk about today. We've got a plethora of new medications that have come along in the last 10 years. We have better glucose measuring devices, new insulin pumps, and also, but outside of the direct glucose-centric world, we have much improved therapies, treatments for cardiovascular disease and other factors. So there's a lot of things in play here, but this to me shows kind of the magic of the power of information, that we had a surprising number of years between the 1920s and the 1990s where there was vigorous debate whether glucose control, intensive glucose control on a daily basis made any difference or not. And I think this spurred research. It spurred greater focus on the fact that we can make a difference. So the rest of this will be about, what is it that we can do to make a difference? I'll be talking about what ADA is doing to try and help this situation. What do we recommend, and what do we provide to help people improve A1Cs and other measures of quality care in the clinical setting? We have a very heavy emphasis on primary care because that's where most diabetes care takes place. We, of course, have as members and are involved with endocrine specialists, but primary care is where these things happen. We provide tools for healthcare professionals that facilitate their following guidelines and implementing them, and we have a wealth of patient resources that for clinicians to give to their patients or refer their patients to, or for patients to discover on their own. I'll start out with basically a case study of can interventions that are really achievable and practical make a difference. We started a few years ago a initiative, Diabetes Inside, which is a program that organizations can elect to have a team come in and help them look at how they're caring for their patients with diabetes, recognize any deficiencies, have the actual providers in that institution reflect on what they're doing with their patients, changes they might make, and implement those changes. And this is not the changes that we're the measures that we're looking at and the changes that are made are not expensive or invasive. It's not a dramatic, costly intervention. I'll get into explaining that a little bit. So the numbers I'm going to show you are from our first pilot of this Diabetes Inside program at Thomas Jefferson University a few years ago. We've presented it as a poster at our last scientific sessions, the data I'm going to show you, and we have gone on to implement this at five total pilot locations, and we're just about ready to begin offering this on a much broader basis. So this is still, I guess it's in the transition from pilot to implementation stage. So Thomas Jefferson invited us in, and they picked about 400 randomly selected patients with diabetes that were being cared for by their primary care providers that were part of the system. When they looked at those patients, they found that 13% of them were at goal for all of the measures shown here. A1C less than 8, not less than 7, LDL, BP, aspirin therapy if indicated, and being non-smokers. So 13% were already there. So good job. We've got 13% done and 87% to go. The first intervention with the providers in Thomas Jefferson was, I think, I hope no one at ADA would disagree with me, as simple as a ground round presentation to the providers and both physicians and allied health professionals who are engaged in the care of patients, talking about what are our American Diabetes Association standards of care. What is it that we recommend that patients be treated to? What exams do they get? At what frequency? Are they referred to a diabetes education program, as we think most people with type 2 diabetes should be? And are the patients being followed up on a regular basis to see if they're getting to their goals? The patients, and we provided access to a program that is actually free and open to the public that we have, Living with Type 2 Diabetes. That is a one-year program that patients can receive for free, either by mail, which I'm still a champion of, or online, which is less expensive and does suit some patients better, of staged information about living with diabetes and how to manage it well over the course of a year. We did a fair amount of work a few years ago to look at what it is that patients think they need to know, what we know they need to know, and what is the optimal time to deliver that. We know that it doesn't work too well to bombard people upon being newly diagnosed or newly committed to making some changes in how they live with everything at once. It helps to prioritize what they need to know. So a lot of thought went into the development of the Living with Type 2 Diabetes program, which again is currently available. I'll show later, clearly referenced on our website. Patients on their own can call up our 1-800-DIABETES number and find out how to enroll. They can go online to do that, and providers can certainly refer their patients to the program. So this was the initiation of the Diabetes Inside program at Thomas Jefferson. Presentation from, in this case, our Chief Scientific Medical Officer, Bob Ratner, on what are our standards of care, what is it that we recommend that patients follow, and then how are they actually doing at Thomas Jefferson in this particular case to comply with those guidelines. We started with some surveying of the professionals involved. There was not always a consensus on what the optimal treatments are for a patient. So it was interesting to discover what they agreed on and what they didn't agree on. One thing they agreed on is that it's often hard to get patients to be willing to move to insulin even when it's recognized that they need it. In different racial and ethnic groups, sometimes you have different levels of resistance for different reasons. So they said, we know there's some challenges particularly on initiating insulin, and there was not always agreement that it was necessary. So after the initial grand round education, the benchmarking of the 400 patients to see where they were, we looked before a second grand rounds at some more details of what was going on with 800 patients at Thomas Jefferson, particularly how they're doing. We now start focusing on A1C. Quality care, of course, involves other things besides just A1C. It involves foot exams, blood pressure, and lipid management. But for the sake of seeing how well this program could work at affecting patient outcomes, we focused on A1C. They pulled 810 random patients that had A1Cs greater than 7. Of those, nearly 40% had an A1C greater than 9, which everyone would acknowledge is in poor control. One thing they found is that they didn't have a great variation within their practice in how the patients were doing. It was fairly uniform throughout Thomas Jefferson in how the patients were doing with the different providers. They assessed what percentage of the patients were on insulin, which ones were on oral medications only, and whether they were on a single medication or multiple oral medications. We found that there were many patients, because there are so many patients in poor control. 40% over 9% is not good, and though some patients, older patients, an A1C between 7 and 8 may be fine, no one would think that this is an optimal set of outcomes for glycemic control in particular. So for our second grand rounds, we went through a more intensive look at glucose control and the algorithm that we've developed with EASD, the European Association for the Study of Diabetes, on the staging of therapy for type 2 diabetes. We developed this, I believe, about 4 or 5 years ago. We've made some refinements to it since. This is not a one-size-fits-all algorithm. We believe very much in individualized patient care, but it does give people a thought process to go through for what you should consider with a newly diagnosed patient or a patient who is not in control, and how do you move, what steps you take to try and improve that care. I'll say quite some years ago, 10 some odd years ago, one of the first things that we did with newly diagnosed patients is to say, do something. Don't do the, well, you have a touch of diabetes, you're just over the border, go away for 6 months, try and eat better and maybe lose a few pounds and come back and we'll see where you are now. We basically say that everyone should be initiated on metformin if they have type 2 diabetes, unless there's some special circumstances, but it's highly effective. It's very safe, it's very inexpensive, and it's got good efficacy. So we wanted to, even at that point, reduce this lag to intervention, which is something that we'll see through the rest of this trial at Thomas Jefferson. During the analysis of these 800 patients, we found that that there was substantial, I didn't show the number, was a substantial percentage of patients who were above 8, as well as that surprisingly high number who were above 9. And there was a very poor consistency in among the providers in following the recommended algorithm. To go into a little detail on the algorithm, we try to take into account all of the real-world aspects of these therapies, the clinical evidence that they work, the acceptability of the therapy for patients, including cost. It doesn't do any good to prescribe an effective therapy that a patient will not be adherent with if they can't afford it. So we take all of these considerations into account in designing this algorithm. And again, stressing that it's individualized care is important. There may be patients for whom one thing is appropriate and another not. Beyond cost, it could be comorbid conditions, age, number of quality expected life years left for them. After the second rounds of really saying, this is the algorithm, this is what you should be doing when a patient is above 8, that if you have a patient who's above 8 and they're on a single oral agent, you should at least consider another oral agent. If they are not on insulin, they're above 8 and they're already on multiple agents, you really need to initiate insulin. So we did a follow-up workshop after that education, I believe 3 months following, to ask the people, a matched group of people who attended and participated in the workshop, the second grand rounds, and those who didn't. And I think these are pretty impressive. This is self-reported. And even it's self-reported where I don't know, I might think that you wouldn't necessarily see a difference because everyone has the basic idea of, yeah, I should be doing this or I should be doing that. I'll say that's what I do. In fact, you see a really stark difference between the percentage of people who attended the workshop who said that they were being more aggressive with the medication therapy. You saw far more people in DISH is Thomas Jefferson's own education program. The people who didn't attend the workshop were kind of routinely sending people to that, but they weren't sending to an actual certified diabetes educator. And you see that, with, well, sorry, that's not the point I thought I was going to make. More frequent patient follow-up, another very important issue. The people who were not being intensified on therapy, and the people who didn't attend the workshop were also not being encouraged to come back more often to see how they were doing. And I think that is one of the simple but key messages we have about implementing standards of care, is just that it needs to be done methodically and more quickly than it traditionally has been. You really need to get patients through the process of care. If they can't get an A1C below 7 and below 8 in 6 months, then you need to intensify that. In fact, you should be seeing them every 3 months when they're not at goal. So the people in the workshop reported these, I think, pretty impressive differences in how they were taking care of people. More of what they said, the workshops were included a questionnaire of open-ended questions of what do you say about how you're approaching diabetes care now following the workshop versus before? And in the first panel, you see that the group who attended, insulin was their most common word in this word cloud. And a lot of references to that clearly focus around the idea of intensifying treatment, of moving forward frequently, increasing it, titrating to an appropriate level. Whereas if you look at the people who didn't attend the workshop, these are also good words, but it's much less obvious that that there's an emphasis on progressing people through that algorithm for intensifying care to get A1Cs to a recommended level. Referrals to DISH, their internal education program, lots of referrals, exercise. The fact is, exercise is not very often going to be a frequent means of really significantly improving A1C. It's going to be medications, and I actually have no idea who Christine is, but she must be someone important at Thomas Jefferson. Well, that's what they told us about what they had done. How did the patients actually differ for those who were participating in this program? We had 57% of the patients who were randomized into this intervention had a reduced A1C. There was a 0.4% difference in A1C between the patients being cared for by the providers who were involved in the program with those who weren't. And they had been identical before. And I think everyone knows 0.4%, if at a P of less than 0.001, that's a pretty significant outcome. If you have that many patients across the board achieving a nearly half reduction in A1C, where the intervention is simply providing recommended care, sending them to the Living with Type 2 program or other patient education materials, and coming back at regularly scheduled visits and intensifying the treatment with standard tools, that's a pretty good outcome for this kind of relatively modest intervention. The providers who were involved initiated insulin earlier. They were more aggressive about adding additional oral agents when needed. Everything you would think of that was a result of the grand rounds proved to be effective. It made a real difference in how their patients were doing. The survey, with the third grand round, when we analyzed the data with the providers, talked about it, some things surfaced in looking back over the program implementation. It was very important that we started with a baseline data analysis and visualization of what the challenges are, not just assuming that, oh, we must need to do this, we must need to do that, but where are the gaps? Then it also proved to be very effective to have very open, clear buy-in from the leadership at Thomas Jefferson. So the people leading primary care within the organization and endocrinology were involved. We had nationally recognized key opinion leaders involved in what are the right standards and how do you implement them. And that appeared to be very influential in getting clinicians to change their approach to patient care. And finally, there was a clear effort to involve the entire clinical care team, not just primary care physicians. It was the nurse educators, the referral to certified diabetes educators that seemed to make a real difference in making sure that the patients were compliant, that they were coming back for appointments as they should, and that those combined elements we attribute to a pretty successful intervention, which I keep repeating myself, but I'm impressed that this was not some sort of complete reworking of their system. This was working within their system, using standard treatments, mostly awareness on the part of clinicians for the need for aggressively bringing patients who were out of control into control, things that they all knew, but they weren't seeing it. So we showed them the patterns. They acted on it on their own, and it had a statistically significant good effect on how these patients were doing. not rocket science, but something that an institution, as we would all think, as high quality and capable as Thomas Jefferson, could still improve from this kind of intervention. Well, that's an example of what we can do with improving patient care. It's not needing new classes of drugs that we don't have now. It's not putting everyone on a pump. It's simply taking the steps that have been proven to be effective but aren't always acted on in a timely or efficient fashion, putting them into practice, and you're going to get improved outcomes. That's what we do with the Diabetes Inside program. That's something that this year we'll be making more widely available. And as I've said, it's really relying on fairly standard tools and resources that ADA makes available. But we do make those resources largely available to everyone. So you don't have to be a participant in Diabetes Inside to benefit from what ADA provides. So I'll spend a few minutes talking about what are those resources that we have, and how do you get to them, how can they be used. This is the Diabetes Pro website, our professional website that really houses all of this information, both for professional education and for professionals to provide education materials to their patients. I'm going to jump down one thing. No one will ever find this website because this is the website that everyone knows. People that have been volunteer professionals that I've worked with for 20 years never go to my website, Diabetes Pro. They go here, and then they complain that they can't find the professional stuff. So I'll tell you, the secret is way up here in this top nav bar. That clicks to the site that I hope people will use. We have done a lot of work on this site to build in a wealth of resources, and I'll just walk through briefly what it is, what we have here, and things that anyone on the call today can go access and refer other people to. Before I get to the focus on improving A1C and those clinical outcomes, some other things that we have available here. We have the Education Recognition Program, which I think many people may know about, that credentials recognized education programs, allows them to be qualified for Medicare, Medicaid reimbursement, and there's a whole section devoted to that. We have a robust set of continuing education courses and opportunities for professionals. Many of them are free. There are both live events listed here, local ADA-sponsored professional education meetings that people can participate in, and a lot of free online continuing education programs that people can participate in. We do have a professional membership that gets you access to our journals and some other benefits. And of course, our big meeting in June, Scientific Sessions, gets its own link because that is one of our biggest efforts. I'd also encourage people, if they aren't now, everyone should sign up for the free Diabetes Pro Smart Brief daily e-newsletter. It's focused, it's topical. This is a little news feed from that, but you click there, there'll be a link to how to sign up for for the Smart Brief for free. I'll go a little bit further into standards of care, which is our most significant tool we make available. It's not the biggest. Some of those are our journals, access to all of our archive journals, current and back 40 or 50 years in the case of diabetes. Webcasts from past scientific sessions. There's a lot of great education on this site, again, that's free and open access to anyone, at least at this time, that we make available here. We have a small slide library for professionals to use, and something relatively new that I'll get to in a second. We have, under our clinical corner, we have a patient education library of a wealth of print-on-demand patient education materials that providers are free to print out and give to patients directly. They can refer patients to them. We link to them from the diabetes.org website. We instituted this patient education library just in the beginning of last year, and it has become enormously successful. So we're getting a lot of utilization out of that. focusing on standards of care, I hope everyone knows this is our published every January. This is our recommendations for the optimal treatment of all patients with diabetes. We cover chapter by chapter a lot of certain circumstances. So we have a chapter on pregnancy. We have a chapter on older adults. We've added new emphasis to weight management in people with diabetes. And of course, for all patients with diabetes, screening recommendations, initial visit components, and all of the aspects of care, all the aspects of individualized care. Certainly, one of our growing areas of emphasis is that patient care does need to be individualized. We've learned over the last few years that you probably have better patient outcomes in the big picture if you have less intensive glucose goals in some older patients with diabetes. There's not as clear sign that they benefit from it. Too intensive treatment can have some negative consequences. So we really try not to emphasize a one-size-fits-all approach. On the other hand, provide clear evidence, guidance for what has been proven to be true and what hasn't proven to be true. So these are evidence-based guidelines, which I'm proud to say we were one of the first organizations to go to an evidence-based grading system for our recommendations, and now it's a standard component of how most people do their guidelines. Back on that home page, you'll see the standards of care. If you click on that, you get to this, I hope people will find, really nice set of resources. We have several different ways to get to the full standards. We have a mobile app that delivers all of them that's compatible with any type of device. If you want to simply see the 100-page PDF and print that out, you're welcome to do that. This Access the Standards goes to the journal site that hosts the diabetes, the full standards of care. Something that we're very excited to do, which my colleague Sarah, who's on the phone, has really been responsible for bringing into existence and moving forward, is an abridged version for specifically targeting primary care. It's, I want to say, maybe still not short, 15 to 20 pages, but it focuses in on the things that are going to happen most often in primary care and leaving out, say, inpatient hospital care, which is in the full standards, or some of the aspects of managing diabetes and pregnancy that usually specialists are involved in. This is really targeted, hits the highlights of what people need to know about our standards of care, and this too is something that just over the last few years has increased enormously in utilization. So we're very proud of this. We list what's new in 2016 in our standards of care, and I wanted to draw attention, get down to the bottom of the page. We have a free CE webcast on the 2016 standards of care that our Chief Scientific and Medical Officer, Bob Ratner, presents. So right there, anyone can get basically the takeaway version of that very first grand rounds that Bob Ratner gave at Thomas Jefferson to initiate the program for Diabetes Inside. Here it is, free of cost for anyone who wants to access it. I've mentioned kind of what are the two sides of the Diabetes Pro website, and more generally what ADA does to educate patients and professionals. We have a good array of professional education information on the Diabetes Pro website and links to attend live meetings. Access to all of our webcasts, by and large, is free. The only exception being when we've had a scientific sessions, that's a huge package of material that we have a fee for accessing those for a while, but then they become free also. So anything that ADA may have spoken on the past, literally tens of thousands of webcasts are available through the site for free. The self-assessment programs for CE credit, we continually update insulin administration, other basic aspects of clinical care. Those are very, we've measured effectiveness and outcomes. Those too are free. Local events. I'll mention we do have, I mentioned before, the education recognition program. Within that, we have a lot of support for diabetes educators in particular. There's the program itself, the education recognition program. If for the 3,000 sites that are participating members, they have access to this Chronicle Diabetes, which is a EMR specifically for educators that contains all the important aspects of care for a person with diabetes. And there are some dedicated education resources just for diabetes educators in that program. Excuse me. I mentioned before the patient education library. So I'm speaking the last minute or so about the education we have for professionals about diabetes. We on the diabetes.org website, of course, is a patient education resource. On Diabetes Pro, you'll find the ability to refer your patients to the Living with Type 2 Diabetes program, as well as this patient education library that has, I think, 150 pieces on diabetes care that we frequently update and cover both the very general, what is diabetes, to specifically how to handle hypoglycemia, a wide range of topics that are, again, freely available for download, handing out to patients, or simply referring the patients directly to them. We do encourage providers to send their patients to the diabetes.org website for their own education. Here, too, they can find out about the Living with Type 2 program. And I hope that this is something that people are using widely. We really spend a lot of time and energy keeping it up to date and informative. I don't know if people have seen this. Just as a side note, we last month launched a national education campaign. The Ad Council launched it with the support of ADA, CDC, and the American Medical Association. So these commercials, if you haven't seen them yet, are running on TV, radio, and print, and will for the next couple of years. We're pretty excited about that because the awareness of the seriousness of prediabetes and the fact that it's a intervention point for preventing type 2 diabetes is not nearly as well appreciated in the public as it should be. We have a few tools for numerous tools on the diabetes.org website that I won't go into in any detail, but just to point out, we do have these resources available, always free for patients to use to help learn to eat better, which is always their number one question to us when they call our call center, is what can I eat? So we try and tackle what they need to know about eating healthy and getting fit. We have it's not an app, but it's a mobile-friendly resource that patients can use for tracking their health data. Diabetes 24/7 is part of Health Vault, and so it interfaces with our application, interfaces with connected glucose meters, blood pressure cuffs, scales, can bring in data from pharmacies. I believe CVS, Walgreens are partners in it. I must say, I thought Health Vault was going to be the miracle cure for the future for organizing health data. So far, it hasn't taken off as robustly as I hoped a few years ago, but it's still there. It's still something that Microsoft is providing for free. It's a stable, agnostic platform for gathering health data. So, little plug for I wish people would use it. And then just wrapping up with what we do outside of the clinical setting. In the community and in workplaces, we have a new program, Wellness Lives Here, which there's information about on the diabetes.org website that will allow companies to implement the program if they meet various criteria for what constitutes a healthy workplace and programs for employees. They can be receive a health champion designation. We engage in health engagement days around the country where we will go into, say, hotels and talk to hotel staff about what they should need to know about diabetes, and if they have diabetes, what they can do to improve it. The program Stop Diabetes at Work provides materials to workplaces that want to introduce some healthy living diabetes risk avoidance or diabetes management techniques, our Stop Diabetes at Work program contains those. And then, of course, we have our awareness fundraising events, Step Out for Diabetes, and Tour to Cure bicycle event in the spring. And just to wrap up, these are the most convenient places to go for patients and for providers to get more information. Diabetes.org is where people always go. Fortunately, it's a pretty well-known destination, and we are very proud of that. As I said before, 1-800-DIABETES is our national call center where the reps have information for patients. We run the gamut of basic things they need to know about different aspects of diabetes care. There's a lot of calls about needing help with being able to afford medications. So they have, we don't provide any direct financial assistance to patients, but we have all of the resources that the companies make available, insurance support, how to get insurance. They're well stocked with information on that. So a patient who's having a hard time knowing how they can afford things is going to get the best help there is out there by calling 1-800-DIABETES. It's still a challenge for many people, but we at least keep that information available for people. And our magazine, Diabetes Forecast, going on 50 years, and really a great resource, free online and at a very inexpensive subscription. And then finally, patients can find out what we do for them in their community. They can call 1-888-DIABETES and find out where their local office is, what upcoming patient-oriented events there are, and within diabetes.org there are pages for the different regions where ADA has a direct patient to a direct engagement with patients through live events and other activities. And I encourage anyone who's on the phone to really use our professional website, professional.diabetes.org, where we have all of those resources available. That's what I have.
Thank you so much, Matt. Very much appreciate it. So at this time, I would again invite anybody who is in attendance to post any questions you may have for Matt in the chat box, and I can convey them to him. I do want to build on the Health Champion designation that Matt pointed out. We will have links to what the criteria are for earning that designation in this Friday's member newsletter and the application form for that. I understand that we do not currently have a main company that has signed up or earned that designation, and your company or organization may already be fitting the bill and the criteria to earn it, and it's great to tout that achievement especially if you're already doing it, or look at the criteria and use that as a benchmark for what you might want to be doing. So with that, let me start with the questions. So Matt, I have a question from an attendee. Do you have any recommendations for how to combine a focus on diabetes with important comorbidities such as cardiovascular disease? For example, do you suggest that delivery systems maintain or promote a separate set of standards and protocols for heart failure management, or creating a combined diabetes and heart failure protocol that addresses both conditions?
Well, you're going a little bit beyond that. That's a more aggressive question for what we have available or what we recommend that I can really speak to. Probably, I mean, one thing I hope it came out what I was saying, though that case study was really intentionally focused on A1C control. For more than a decade, ADA has really said that quality diabetes care involves much more than glucose control, and does address, with the primary adverse outcome we're looking at being cardiovascular disease. We're looking at integrating all aspects of improving health care for a patient with diabetes, definitely not just glucose. So it's blood pressure and lipid management in particular, or anything having to do with reducing cardiovascular risk is the #1 priority. So how we recommend those, whether they be isolated or combined, I mean, I can only say my personal opinion is I believe we consider comprehensive diabetes care to include all of those risk reductions. And it can certainly be that there's a greater emphasis for a particular patient on the risk factors, blood pressure and lipids, say, if they're out of control, that can be the most important thing to intervene with right away, particularly blood pressure. Yeah, I think any endocrinologist would say if I've got someone with a blood pressure of 180 over 130 and their A1C is 8.5, I'm going to worry about the blood pressure. So I don't know if that answers the question specifically about how we recommend that the care delivery be organized, but we certainly believe it's important.
Okay, well, I appreciate your answer as best you could. Do you do you have any recent changes to the 2016 standards of care that you could speak to?
There's a few. It is an evolving document. We haven't had any dramatic changes in the last few years. This year really expanded our focus on obesity management and type 2 diabetes. There's a lengthier section on the pros and cons of bariatric surgery, a recognition that it's one of the more mutable aspects, though difficult to change, of good patient care in a person with type 2 diabetes. So a new emphasis on weight control and the handful of medications that are available for that, strategies for patient counseling on weight management, and bariatric surgery as well. We have some new information, expanded, clarified information on diabetes care in the elderly. There's one more I would mention. We've clarified some of our guidelines that are technical but important about when to intensify blood pressure management. A couple of years ago, we raised our intervention level from 130 to 140 systolic, and then we've also now raised our diastolic from 80 to 90, saying that the evidence basing all of our recommendations on what's really been proven. We haven't shown that, it hasn't been shown that those final pushes down are effective and come with some consequences. So I wouldn't use the word loosened, but I'll use it, loosened our blood pressure guidelines a bit, changed our recommendation a bit on aspirin therapy. By and large, I think we're comfortable with where we are. I think it was also a big picture. ADA was never in the vanguard of saying we've got to push A1Cs as low as possible, because we knew there were consequences with that. And we all know that a few years ago we found that through the ACCORD trial in particular, that it was maybe we're making a mistake with some patients in pushing too low. So we recognize that even before ACCORD came along. Since then, we've really changed the emphasis to individualized care, that there are different A1C goals as well as other aspects of care that need to be individualized for a patient given their exact characteristics. You treat a patient who's got 10 years to live and this set of comorbid conditions perhaps very differently than a patient with 50 years to live and no comorbid conditions. So I think the changes are continuing evolution of the need for individualized care and the other things I mentioned.
So what you're saying is that the A1C is not necessarily always the primary goal of improving patient care for people with diabetes. It can vary based on the individual?
Yes, I mean, it is still central to what we know that glucose control, back to my very first slide, is critical for reducing complications. So it is a central point, but exactly in a given patient, given their particular circumstances, it may be that A1C is not the most important thing to address. It could be any of a number of other factors, lipids and blood pressure or something. If a patient is in somewhere along the stage of renal failure, or if they have serious infection, foot complications, there's different things you're going to have to emphasize. A lot of that's obvious, but I think a lot of it hasn't always been reflected in the patterns of care of people kind of applying a a rule. Well, they're meeting this criteria and this criteria and this criteria. We'll see them in 6 months. But we really want to emphasize the need to address the issues that are of the most important health consequence for that particular patient.
Okay, appreciate it. Well, I think that's probably all the questions that I see coming across, unless anybody wants to get one in here at the last moment. So I thank you so much, Matt, for your time and sharing your expertise and all the resources. It's amazing how many resources you have. And I hope people do take advantage of them. So again, this webinar recording will be posted on our member website. And if you have any questions about it, please do let me know. Thank you very much, and I hope you all have a great afternoon.
Thank you all for joining.